Bernalillo County. And during the pandemic, Enrique has led the Bernalillo County Community Health Council to become a hub for reliable and accurate information related to the pandemic. He has skillfully facilitated conversations related to social justice and equity, and we're pleased to have him here to discuss economics as a social determinant of health. Welcome, Enrique. It's yours.
All right. Well, thanks for having me. Andrea's going to drive the thing here. Just hopefully that works out. Yeah, so my name is Enrique Cardiel. I've been the director of the Health Council for a couple of years now. I started working in public health in 2001. And in 2012 is when I attained a master's in public health, just because it seemed like I had maxed out what I could do without that. So we'll go to slide 2. This was a presentation I did at New Mexico Public Health Association. So I started in health promotion, and health promotion is a subfield of public health. And I think that really has led me to, to certain things. And so health promotion exists within the context of whatever the political economy of each country is. So social democratic countries and liberal countries, and regardless if we have a Republican or Democratic Party government, we're liberal in the sense of what's called a capitalist economy. So sometimes that term gets confused by folks. So we're a liberal country, even when Democrats are not in power. Just for, I know that can be confusing to folks. But they both those talk a lot about public health. Liberal welfare states, which is what we are, talk a lot about public health, but don't invest in it. So we'll go to the next slide. Oh, I forgot I had transitions. So health promotion is, to me, really the key of what I try to do in all my public health work, right, is enabling people to increase control over their own health. So it's not that I'm doing anything or that we are doing things for people. It's people doing things for themselves. This logo represents the kind of 5 key principles, which is public policy, community action, supportive environment, personal skills, and health services. And so obviously, I think the area that we've don't work on enough is community action. And I think that really will encompass a lot of the other ones. All right, next slide. And then the prerequisites to health. Oh, my fancy stuff got in the way there. All right. Different than don't smoke and don't eat fast food and walk around. The prerequisites for health from the health promotion field are a little bit different, right? Peace, shelter, education, food, income, stable, environment, sustainable resources, social justice, and equity. And the charter for health promotion, the Ottawa Charter for Health Promotion, was put together years ago, right? So these are things that I've looked for. How can we put together from the public health that we do, whether I'm working on diabetes prevention or substance prevention or, food security or any of those other issues. Okay, next one. And I'm going fast just because I'd rather have people time to talk. If I'm going too fast, somebody please let me know. So our economy matters. We talk about low-income people, or we talk about poverty, But really, those things are in the context of our entire economy. And I think that's big and overwhelming, but I think it also helps us kind of figure out what we can do locally. Next slide. Capitalism defined. So I usually don't read to the audience, but since I can't see anybody except Karen, I will go ahead and read. So it's the production of goods and services for the profit of those who own the means by which they are produced. The major means of production are private, right? So basically the people who own the businesses are the ones who receive the profit, or that's who the profit's primarily intended for. This was written by Vicente Navarro, who's a public health professor. And so he's done several comparisons of public health and health outcomes in capitalist and socialist countries. And there's probably lots of conversations we can have there, but we'll go to the next slide. Yeah, so one of the early commentaries that started the field of public health in the Western sense was this idea of causing early death in parts of society through structural exposures that kill people early. And so we know homelessness kills people early. We know poverty leads to a lower life expectancy. Yet, we allow people to live in poverty in this country. We allow people to be homeless in this country. And so I put the link there for people if anybody wants to look that up. I can send a PDF of the presentation, or Andrea could make it into a PDF and send that out if that's appropriate. But we'll go to the next slide. Right, and so here's a long quote. I'm definitely not going to read this quote. But yeah, so one of the early public health analysis on a population level was the condition of the working class in England back in 1845. So my understanding of the story behind this is that Frederick Engels wrote this and was fired for writing this. And it's, through a lot of lobbying and things, he was finally rehired. But yeah, he basically says, like, if society has the ability to prevent bad conditions that kill people and we choose not to, then we're committing social murder, no less culpable than an individual who harms another person to, causes them to die. And I know that's hard for us to take on. And it's not what we're usually taught to think about, but I think it's really important for public health folks to think about, what's the broader context and what things are preventable. Next slide. Right, so here we go on social equity, right? There's lots of models, and so I pulled ones that I did my research for my MPH, right? So 119,000 deaths are based on income inequality, on average per year. And that sadly used to seem like a huge number to me until we started counting COVID deaths. It's going to be a while before anything compares to that, but I really think it's important to look at that income inequality that causes that many people to die every year. And they did separate out for education, segregation, poverty, area poverty, those things. So that's an attempt to look at how much social and income inequality impacts folks. Next slide. So take a second and appreciate Tom Sherman, who's no longer with us, but his data led to a lot of my work. Tom and I worked together since 2001. And so just looking at how much people die from diabetes based on their income, right? And the poverty level of where they live, right? So this doesn't necessarily mean it's, individual, but if somebody living in a sanctions tract with higher poverty has much higher likelihood to die from diabetes before 65 than somebody from a lower poverty rate. And this is Bernalillo County, so this is not just a theoretical thing. It is slightly older, 2001 to 2005. Just from my time in public health, I don't think we've done anything that would significantly change this. But we'll go ahead. Next one. Oh yeah, there he shows the city of Albuquerque, how poverty is distributed. All right, next one. So the Urban Heart Tools Health Equity Assessment and Response Tool did a lot of research, and so there's this child mortality based on poverty by 20%. So in a variety of countries, you see essentially the same thing. But, each country has some individual changes. But even we're a country that has high under 5 mortality rates for the richest folks, still has an even higher rate for folks who are less well off. Okay, next one. Capitalism versus socialism. So this comes up a lot during election seasons, but really I think there's important things to discuss outside of elections and really looking at what things are. So really folks that identify as socialists have put more effort into public health than folks who identify as capitalists in general. These are generalities that he's talking about there. And it's important to note that I forget the name of the northern region in Italy that's been studied a lot. But there's also a region in India called Kerala that has been studied a lot because they have much better health outcomes than the rest of India. And one thing that gets left out of a lot of those assessments is that both of those areas are locally run by, a strong communist party. And I know there's issues where that hasn't worked out for folks, but I think that even within capitalist countries, small areas where people were dedicated to a more distributive economic system have made some impact. All right, next one. And the fun part that we usually don't get to talk about in nonprofits is politics, right? So politics matters because that influences it's the other part of the political economy. Go ahead. So Navarro also led a study where they looked at mortality, union coverage, voter participation, style of government in industrialized countries. And they did like 50 years of analysis. And so they came up with these things that I do like to read. For every 1% increase in votes for social democratic parties, infant mortality declines, 0.15 per 1,000 live births, right? So we can always say that's not a huge number, but if it's your child, it's the biggest deal, right? For every 1% increase in population participation, that means just voting in general, infant mortality declined 0.13. So the U.S., I can't find this. The site has changed their setup. There is a site in, I believe, Switzerland that laid out election turnout by country for the, I think, 186 countries that have elections. And the U.S. ranks between 111 and 120 in any given year. So our voter turnout is far from the top of that. So we could, and it's because the more people vote, different things get influenced, right? Usually the people that don't vote are people who feel that the system's not working for them. They're not represented. So the more that you can actually get folks to participate because they feel represented, there's dynamics in the system that impact, infant mortality. All right, next one. And I'm seeing the things pop up in the chat. I appreciate that. So most Western systems, we have some kind of proportional representation that allows for more than two parties. Often, those having more than two parties often leads towards more cooperation. The two-party system leads to what we get in the United States. I don't think I have to describe it. Great. Oh, go ahead. The other thing that matters is union participation. There's lots of studies that show that more people participate in unions, lots of health outcomes change, right? It's not just money, but it's dignity, health benefits, it's, education services, lots of things change. The US has probably the lowest union participation it's had in the last 100 years. And so I think I'm in a lot of meetings where we will get together and someone will say, well, where's the local business participation, right? We don't have any local businesses here. And I don't think that's a bad thing. I think that's a great thing. But we should also ask, why isn't any unions participating in this conversation, right? Why aren't union folks here? For prevention, right? Unions would be great if you had your workplace telling you, giving you prevention messages as well. I think that would, definitely be something better. Let me ask. Yeah, the coalition governments usually come out of proportional representation, and those tend to do better. Because things tend to do better doesn't mean they always do better. So sometimes they work great, and places where you have to have coalition governments overall tend to do better for public health, but they don't always, right? They also have problems. Next one. Okay, so here, one thing we do, and we're trying to figure out in the Health Council, is contract work, right? Or what we call gig economy now. Folks who have a permanent job tend to have better health, mental health, than folks who, are temporary, could be laid off very easily. There's issues for women, and I didn't review this and read the reason why the women is higher under permanent than fixed term temporary. I'll have to go back and look that up. But in general, figuring out the type of work you have, part of that is unionization. Part of that is how we allow economies. We don't value, for example, cabs anymore because we can do Uber. But a lot of cab companies were unionized. So I think, we're really doing, if we can afford it, I think it's worth spending the extra money to support union folks. And there's just times we can't afford it, right? Not everyone can afford to take the most expensive route. So I think we need to have some kind of compassion for folks who just have to take the cheapest option, don't have a choice. But if we have a choice, I think supporting places that are unionized, places that support their workers or pay a living wage, are, it's small individual, but important practice. Next one. Privatized politics. So in some countries, politics are paid out of, campaigns are paid out of government funds. And so essentially everyone has an equal footing as far as access to resources to campaign. There's always ways around it. People always find ways to trick their systems. But in the US, we have a very much privatized politics, right? Where whoever can spend more money gets more voice, right? I believe Navarro did an article in 1976, and it was the first time that there was a survey done where 51% of the population thought universal health care was the way to go. And we're in 2020 now, and that number has gone up, but we're not very much closer to it than we were in 1976. So I think that, he's making the argument that has to do with the fact that you have to have lots of money to run for office. And so the folks who get elected are much different than the folks that they're supposed to represent. Next slide. So here's, I'm trying to remember the book. It's, I think, Rich Countries, Poor People, or Rich Democracies, Poor People by Brady. Basically talks about, what we call welfare, the welfare state. And he makes the argument that proportional representation that allows a left politics to influence the government influences the welfare generosity of the state, and therefore that reduces income, inequities, and also alleviates poverty. This argument seemed like it was holding for all countries till about 2010 or so. I think the last economic crash has just impacted lots of countries, and this model may not be as solid under this level of economic instability that we've been dealing with. Next slide. So, reality, again, nonprofits. I've worked for a nonprofit or a government agency probably the last 30 years of my life. And so we're not supposed to engage in politics or talk much about politics, or we're discouraged from it, even though legally we're, even nonprofits are allowed to engage in politics to some level. You have to be very careful and specific about it. But really, our politics provides which parties are in power, and the parties pick what policies are in power, and that gives us our health outcomes. And so I think, if you're super limited at work, that's understandable. Think of what politics you really truly support and what health outcomes go with that, and and follow your own judgment, and participate. Next slide. So this is another Tom Sharman slide, and it just shows, again, all causes of death combined, and by the amount of poverty in your census tract for Bernalillo County. And it's fairly consistent across the board. Indigenous folks have a slightly different graph, but it's still fairly much the same overall. It's still similar outcomes. And so I think it's really important to think, I was at a conference where they were talking about taking people out of high poverty areas and moving them into areas with less poverty as a way to increase their health. And I think that's great on an individual level, but by doing that, you're also saying we're not going to try to change the fact that there's communities of concentrated poverty, right? Because that doesn't impact poverty, it impacts those individual folks' health. So I think we have a long way to go to figure out how we want to do this. I think on some level it's very easy or very simple, but it's not easy. It's going to be very hard. Next slide. Oh, this slide died. Okay, well, I don't know. I can't fix that. So this was going to show you poverty in Bernalillo County. Maybe try the next slide, see if that works. Okay, I'll try to fix that before I send Andrea the PDF. So it just showed concentrations of poverty. If you know Bernalillo County, poverty in south and of I-40 tends to have more poverty than north of I-40. And I-25 has a corridor of poverty that goes along with it. Okay, next slide. And I'm going to respond to the comment in the chat real quick. So, some policies are consistent regardless of which party in power, such as the mass incarceration, war on drugs, and all the racism and stuff that comes with that. And that goes to the argument of folks who see the two major parties that we have in the U.S. as not being that different. I don't think it's fair to say there's no differences. I think there obviously are differences, but there are some things that are very much overlapping and very similar. And yeah, I don't know if it's appropriate to give all my comments and thoughts on that, but I think the parties are closer together now than they were in the 70s and the 60s. And they seem, sadly, to continue to get closer. So I'll go to this next slide here. So this was interesting this is from the World Health Organization. They put out their giant social determinants of health document in 2007 with the idea they were promoting that if we wanted to, we could achieve equity in one generation, which I think is true. The problem is the political will is not there to do that at this point. We're not even dealing with climate change, which is something that impacts everybody regardless of where you live or background. But here it talks about suicide and the number of factors for Indigenous young people. And so land claims, self-government, education, police, fire services, health services, and cultural facilities are the 6 factors. So if you have 0 of those, you see how high it is on the left. And the more of those factors are present for Indigenous youth, you see how it goes down to almost, I don't think it's exactly 0 on number 6, but it's almost 0. Next slide. So for people who do public health, you know that changing social conditions and housing and education and work conditions improved life expectancy more than medical services did in the last century. This research believes that for the money you spend on achieving social equity, you'll get 5 times more return than what you'll get if you spend that money improving medical procedures. Next slide. Oh, here's a fun one. So Giving everyone the health outcomes of the college educated may save 8 times as many lives as, more advancement in medical services, right? So whether that means figuring out how to give folks the same kind of health and work control that you have if you have a college education, or maybe giving everyone a college education. Right, I think you can read that in 2 different ways. But this definitely is part of the argument for, well, I don't know if it's part of the argument people think of when they talk about free higher education. But for folks who believe in free higher education, I think you should add this to your list of arguments. Next one. All right. Poverty impact on lifelong health. Right, here's a list of things. These are all the things that a lot of us work on. This study didn't have anything specific around directly related to substance use, other than they did point out that alcohol and other substances are involved with things like homicide, cirrhosis, and unintentional injuries. Okay, next slide. So here's a model that some people use to work on, and I've used myself, right? So the inside is like age, sex, and your hereditary factors. The next circle out are the individual things that we traditionally look at, safer sex, exercise, eating your diet, drinking, smoking, those things. The next level above that is kind of the environmental factors, right? Your living, working conditions, education, housing, healthcare system, water. And beyond that are what they're labeling as the social determinants of health equity, right? How much racism, classism, and sexism is in society. And, there's all the other isms. There's a lot more isms than those 3. And so, fundamentally working on all those levels is important to look at. How do we change the systemic biases, right? Systemic racism, systemic sexism is important. I listened to somebody this weekend who doesn't like the use of term classism because they feel like it's narrowing down class power issues to just prejudice. But I think really, working on class issues, this is intimately tied with working on race and gender issues as well. Next slide. So health enhancing policies, right? A living wage, increase the minimum wage is actually good for life expectancy. It's good for the higher education outcomes of the children of employees. It actually provides more productivity for work, the people who are employing folks. The one negative outcome of increasing the minimum wage in everything I saw is people will have more expendable income for alcohol. So actually the number of people that drink is usually much less than what we think. And the prediction is increasing the wage will means that not just middle class folks can have their shot of wine or whiskey in the evening, but affordable housing, obviously we're seeing now how much housing is a big issue. Urban recreational space, taxation, all these other things that we know. There's probably a lot more. Go ahead. Next slide. All right. So voter registration, unionization, right? How much we spend on education, pay equity. It's amazing that you can still show um, gendered and racial differences in pay equity in the United States. We have a lot of work to do there. Um, Proportional representation, again, 2/3 of the time that leads towards a more public health friendly environment. 1/3 of the time it doesn't, right? So there's no guarantee. But I think it's important. And when you look at population health, right, we're going by odds, not by guarantees. Next slide. All right, I was done. So I'll open that up for comments. It has my correct email. I'm good. Any questions people want to do verbally? I don't know how much time we have left. So
You have about 20 minutes, 20, 25 minutes.
all right. So in the chat, examples of systemic racism or classism. I think systemic classism is, you can see it in the news. So this week, Amazon hired an anti-union consultant, right? A union busting consultant to keep workers from organizing under the company of the richest person on the planet. So if anybody could probably afford to pay their workers a little more, it's probably the richest man on earth. But the fact that they're going to hire people to make sure they can't unionize, I think is part of the systemic. And that happens in lots of places. They suspected I was going to try to organize in McDonald's when I worked at McDonald's. And so I was harassed immensely. They didn't know I didn't know how to organize a union, but they thought I did. So, I think those things, and just how we treat homeless people, if you want to look at just classism, the fact that we kind of accept that they don't get public restrooms, how people treat them, treat folks who are unhoused, that people are willing to like beat them and murder them, right? I think is on some level systemic, and just the fact that they there's a lot of laws and structural things that are intended just to harass unhoused folks. I think that those are their I think as far as systemic racism, redlining is not as easy to get away with as it used to be, but it still happens. And that's where you keep people from living in certain places. And racial profiling by law enforcement is part of systemic racism. But I think there's also just in education where there's still lots of research that shows that teachers treat people from different backgrounds as if they have different capabilities, right, because of their racial background. So I'm getting asked in the chat, how can community programs support this type of work? I think really, having these conversations within the work we do is a key part. People need to know that there's places to talk about this, and when you do, then you start looking at how can you help communities organize in a way where they can solve these things. Part of it is we need to trust people to have solutions on the local level, right? Because nobody knows better what you and your neighbors need than you and your neighbors. Our job is to help folks get right information, right? Sometimes people come up with the wrong answers because of who we listen to as far as, political advice or social advice. But really trying to provide data, right? Hard data, on our end, but really having the conversations with folks that help them come to an awareness and try to figure out and encourage them to figure out what they want.
Enrique, there's a comment in the Q&A box from Bernie that says, if we don't evolve a critical consciousness and act on it, we passively participate in propagating all the systematic isms.
Yeah, I agree with that. I think if, there's lots of different ways of doing this. So for me, from health promotion, the best way to give community people their power is to help them organize their power. Most people have power, have some agency. We just usually get in the way by trying to do things for them. So I think us dealing with our biases around community folks is important so that we can help folks find their own power and help them find, the right leadership to help them move that power into actions that'll support their communities, right? I think given that most of us work at a county or sub-county level, we start with where we're at. And so having few conversations with folks and a few kind of organizational meetings where you get people together and help them think, what do they want to do? What do they want to solve? The hardest thing I remember as a public health worker, for the state was I'm talking to people in Southeast Albuquerque, right? The Native communities had their biggest health concern was police brutality. That's what they felt was their biggest concern. And we're coming into communities saying, here, we're going to give you a stop smoking program. And I think, smoking is important or an issue to deal with, but also we have to find some balance of listening to folks and how we might still have our contract or our obligation to do our issue, but we can also help folks figure out their issues and how to work on those issues. That will hopefully make our issue that we're coming to them have a little bit more credibility, right? Because they'll trust us because we've listened to them. And, I remember yesterday during Pelatia's talk, somebody said, you don't want to stigmatize law enforcement while you're trying not to stigmatize other folks. So that's always going to be a balance. Let me see, there's another one. Okay, I'm going to read this one because it's long and maybe it'll stick in my head if I read it. We've been talking some about building structural competency with prevention. I think that this discussion goes far in helping us all build structural competence, understanding how structures of power influence people's lives. We capitalistic societies have a foundational ideology that folks' health and economics are a matter of their choice alone. That's true, right? We have a very individualistic approach, and I think we need a balance, right? That we live in systems. And so I know I'm healthier when people in my household are also doing better, and if they're eating better. If one of us goes downhill, we kind of all go downhill. And I think that's true, in community settings as well. And I think the one thing we don't talk about enough, and it'll probably be my next NMPHA presentation, is power and public health. Because really, we often talk about resources, right? People don't have enough resources. Well, that's usually because somebody with power has decided how, resources are going to be distributed. So I think beyond resources, really power is important. There's research shows that the amount of control you feel at work is very strongly correlated to your odds of heart disease. And so I think, the same is true probably in the rest of your life. So, the more you feel agency throughout your life, probably the healthier your heart's going to be. But the more areas where you're feeling powerless, you're more than likely dealing with that stress, whether you're paying attention to it or not. So I'm glad that was helpful. The one great thing about Zoom is no one can throw anything at you. Wow. Oh yeah, my background's already on fire. I know. I was at the beach for most of the pandemic, but after New Year, I decided this is more realistic. But we'll get through this. Sadly, we lost way many more people than we should have, but hopefully we figure out how to come out of this stronger. And I think really the last year for me personally has just led me to reflect on the importance of power and community power as part of public health. And I think really that community agency will figure out how to get funding to do it right. We can do a little bit. Since I'm the director, I can do some with or without funding, but it'd be great to actually have public health organizers on staff that can really focus and really build power and help communities kind of deal with the issues they want, while we still do programs where we're helping promote things, that the state or other places have decided are important to work on.
I just wanted to say one thing that, thinking about your slides and that one that had the circles embedded within each other that talked about different layers of factors impacting people. And at one point, of course, it was the social determinants of health. And thinking of those factors, the more we can strengthen those factors, those are protective factors when we can strengthen them. They obviously become risk factors when they're not. But from a prevention perspective, that's how I tend to think about it, is it gives us a place to look at for what can we strengthen to try to improve the health of our communities.
Yeah, I mean, I think it all comes down to looking for ways where we can actually do something, right? So it's just kind of picking out all these different things. So I think anti-racism training or anti-oppression training, I think that's useful. I think it's more helpful when people are deciding to organize something around that, right? And like, what do they want to change? What do they want to improve? So the easiest question for a conversation is like, what are 3 things you want to change about or improve about, your workplace, your neighborhood, your county? And I think from there, you start the conversations and start to figure out, like, how do you map it out? How do you figure out? One thing that we're not good at in public health, or not good enough at, is figuring out where are the levers that are going to change the things that people want changed. And I think that has to do with just the paradigm of us coming in as helpers. And I think we really need to come in as how do we become one with the community? How do we interact with the community in a way that we're not outsiders coming in?
I really like the comment of, I got to back up now to find it, Alicia saying, asking if she can do a social work practicum with you.
Oh, sure. Send send somebody my way. I just put my email in the chat.
Great.
I'm terrible at email, so I'll just say that now. Well, not terrible. I just have a lot of email. Karen knows. Karen sent me an email once. I remember this. She sent me an email once in March to say she had sent me an email in January and then a reminder in February.
We understand you're busy. Understandably so.
So yeah, so send an email and feel free to send more than one if you need to. But no, I'm happy to work on this, and I really our health council meetings were generally presentations to people, and this year what we're going to try to do is have more conversations where people can be. All right, an anonymous attendee. What do I think of law enforcement prevention strategies in New Mexican communities? I think each community is different. I think I did a group with some law enforcement in Bernalillo County, and you know, it was about the party patrol, and they talked about the inequities and how it was implemented. And that resulted from whose family had lawyers to file complaints if law enforcement showed up. So I think they started out attempting to be equitable, but then the fact that some families have resources in some neighborhoods more so than others, you know, and where are you more likely to run into somebody's parents who are lawyers and those kind of things, changed how it was implemented over time. So I think there's a lot of factors that could impact how law enforcement interacts with prevention. So I think, you know, each community is different. You're going to have to break that down. You know, and if you can have respectful and hard conversations, it'll probably be better. I mean, I think that's the thing we have a hard time with is, you know, how to have those hard conversations and be respectful. So that was from the question and answer side. I don't know if there's anything else. Well, I'm honored to be here. I didn't know, I had no clue anyone would want to hear this presentation again.
I think you've got a audience who definitely likes hearing what you have to say here. It's fertile ground, and they do lots of important work in their communities. So
yeah, no, I mean, it's a great community. I really miss being able to walk in the room and hang out with folks, but at least we were able to do some things together. There's been a lot of great presentations.
Thank you. Well, we've certainly enjoyed yours. Thanks so much for coming and talking to us. Does anyone else have any other questions? It doesn't look like it. Well, thank you. Thanks again, Enrique. Thanks, everybody. We really appreciate everybody for attending the OSAP recipient meeting. We've had lots of great presentations. We look forward to seeing everyone in August. If we can't see you in person, we'll certainly be doing it virtually. In the meantime, if you have any questions, please feel free to contact anyone in the OSAP or COOP consulting office. We hope to see you all tomorrow. We have the State Epidemiological Outcomes Work Group at 1 o'clock. And we'd love to see you all there. So thanks again to everybody for participating with us. And we look forward to seeing and talking to you soon.